Welcome to Beyond the Biopsy. My name is Nitin Yaram. I'm a urologic oncologist at Hackensack University Medical Center. Today, I'm actually really excited to be able to introduce Dr. Gopal Gupta from Loyola University Medical Center, who's going to talk to us today about small renal masses. So, Gopal, I think the problem that we've had, it's a bit frustrating, I think, over the last few decades, is the dogma between small renal masses. So today, when we see a 3-centimeter mass in the clinic, what does that workup look like historically?
Well, this is a problem that urologic oncologists, urologists deal with every day. It's almost like an epidemic of small renal masses. Because if you go to the emergency room today, you're probably going to come out with a scan. It probably didn't address the issue you went in for, but now you have a renal mass.
Yeah.
So the incidence is up. And we have new techniques to deal with them, surgery, observation. But really, we want to make sure that we're dealing with cancers and not operating on non-cancerous renal masses.
Yeah. I mean, I think that what is the chance that you kind of quote patients that their 2.5-centimeter mass, they're found incidentally on CT or MRI, is likely cancer?
Yeah, so if we define small renal masses as, let's say, less than 4 centimeters, so
Yeah.
T1A,
Yeah.
the textbook would be 25 to 33% of these
Okay.
are non-cancerous.
Yeah. And so what does that workup now look? So let's say you see somebody in clinic with a 2.5-centimeter mass. They have a CT and MRI, or that shows that they have this mass. What is the next step? Well, what do you tell those patients?
So repeat the MRI.
Yeah.
I really like MRI in this space.
Sure.
For renal masses, if we're not dealing with stones, the MRI is really nice at looking at the parenchyma
Sure.
and the mass.
Yeah.
Contour, size, enhancement, location. And then, of course, as a surgeon, you're looking at shared medical decision making.
Yeah.
How old is this patient? Do they have risk factors?
Sure.
You're trying to divine what is this cancerous?
Sure.
Is it not cancerous? Is it growing? Is it a threat to this patient's life?
I think there's no question that's the case. And then in addition, like many other cancers that I think we deal with, in our sister disciplines, a biopsy has really been used as gold standard. But in the renal mass setting, that's not always the case. So why has renal mass biopsy not been used as kind of standard of care for all of our patients?
Well, renal mass biopsy is not without risk.
Yeah.
The other thing is most urologists are not performing renal mass biopsies.
Yeah.
So you have to give up some of that unknown uncertainty to another provider,
Yeah.
usually an interventional radiologist. Depending on where you are, you may have a good relationship with them, you may trust them, you may think they're very good. The other issue is not all masses are amenable to biopsy.
Yeah.
The kidneys in the retroperitoneum,
Sure.
there's colon, there's other vital structures. Some of these masses are anterior, they're polar, they can't be biopsied safely. And renal mass biopsy, that too is a very interesting topic. It has evolved,
Yeah.
and it is relatively safe, but you're still putting needles in patients.
Sure.
You're still doing anesthesia. There's still a risk of bleed, albeit that's low.
Yeah.
And then there's this, I think the real kicker is is it truly diagnostic?
Sure.
Can you tell histology? Can you tell the aggressiveness of the lesion? And the other thing is, did you hit the lesion?
Yeah.
What do you do with a negative biopsy?
Yeah. So I think biopsies for sure have evolved, but I think the challenges remain in terms of how accurate those biopsies are, and there can be non-diagnostic, a significant amount of times, which kind of brings us to, I think, the first tool that over the last few years we've seen a growing interest in, and that's the SESTIM-EB scan. So let's set kind of the stage for the audience. What is the SESTIM-EB scan, and what's the biology behind it?
So SESTIM-EB is a molecule that it passively infiltrates cells, and it binds to what we call the powerhouse of the cell, the mitochondria.
Okay.
A lot of people will say SESTIM-EB for kidney. I've heard of SESTIM-EB for heart.
Yeah.
Well, heart's a pretty active organ. Has a lot of muscles, myocytes. It's loaded with mitochondria. So that's a nuclear stress test. Now, one of the forms of solid renal masses that isn't a cancer is an entity called oncocytoma. And oncocytomas have a high abundance of mitochondria. We don't really understand why.
Okay.
But that makes sense. If SESTIM-EB likes mitochondria, maybe SESTIM-EB will accumulate in a oncocytoma,
Okay.
and we might be able to reveal that.
So a positive SESTIM-EB scan where it lights up is more indicative of a benign tumor such as oncocytoma, correct?
Right.
Okay.
So if you look at the spectrum,
Yeah.
there are over 15 different types of kidney cancer
Yes.
in the AJCC.
Yeah.
But 80% roughly are clear cell renal cell carcinoma.
Yeah.
And that's the most aggressive phenotype.
Correct.
Right? They grow faster, they can spread. Then you have papillary type 1. And then you have this spectrum of chromophobe, which is actually a cancer,
Yeah.
and then oncocytoma. So the
Yeah.
spectrum is chromophobe, oncocytoma.
Yeah.
One is benign, one is cancer.
Yeah.
They both have mitochondrial dysfunction.
Yeah.
They both can accumulate sestamibi.
Yeah, and I think one of the clinical dogmas is how do we differentiate between onco and chromo when it comes down to either biopsy or on imaging, which we'll get to that in a second. But let's just talk about sestamibi again. Let's look at the data. I think there was a recent 2023 article that kind of talks about the specificity and sensitivity. Help us understand how accurate is the sestamibi scan?
Yeah, so there's been a lot of data with sestamibi because it's exciting.
Yeah.
There's an agent that could potentially
Yeah.
allow you to see a non-cancerous tumor.
Yeah.
So the data, I would say, is somewhere between 80, 85. Some papers have quoted 90%
Okay.
sensitivity.
Okay.
But again, the problem is specificity.
Sure.
And so that's also been in about the 80, somewhere from the 65 to 80% range,
Okay.
which isn't great.
Yeah. Yeah, and I think that poses a problem. Like, again, how are we going to use this scan to interpret the results in a pretty accurate way in that sense, right?
Yeah.
Where does the sestamibi scan fit in that workflow? Is it something you would typically use in the pre-biopsy setting or in the post-biopsy setting, or is biopsy not even included in this workflow when you have a sestamibi scan?
Well, there's some features that suggest that this mass may be non-cancerous, like
Okay.
an oncocytoma.
Sure.
So you're going on that hunch.
Yeah.
You get the initial MR, the CT, and as urologic oncologists, we're used to reviewing these ourselves. We see what the radiologist says. They often don't comment on histology. It's not in their purview, really. So we look at it and we go, oh, that's interesting. Could that have a central stellate scar? Kind of what's in Campbell's, some of these things that are indicators for oncocytoma.
Yeah.
And if you think that, you assess the patient, and you're on this hunch, you could say, well, let's do a biopsy. You do a biopsy, it comes back oncocytic neoplasm, cannot rule out chromophobe, but favor oncocytoma. Well, that doesn't really help
Yeah.
because one's a cancer
Yeah.
and one's not cancer.
Yeah. And I think that's a great segue into kind of the next non-invasive tool that we can use and to help kind of even further differentiate between oncocytoma and chromophobe, and that's the MRI metric peer that I think your group in Loyola has really been active in this. So help us understand what that metric is and how do we use that into our workflow?
Yeah, so when we're evaluating renal masses, right, you're looking at enhancement, that's a key one. We kind of did a back of the napkin, I would show residents. If you look at the enhancement of an oncocytoma, like a known oncocytoma, you
Yeah.
took it out and you're like, oh, dang, we did this surgery, it was benign. But if you go back and look at those, they enhance very early.
Okay.
So if you had time on the x-axis and you had enhancement on the y-axis, oncocytomas are early enhancing and they enhance a lot
Okay.
compared to clear cell.
Okay.
We're in the era of AI.
Yeah.
MRIs are sophisticated imaging tests,
Yeah.
but the radiology report often isn't sophisticated.
Okay.
They don't even tell you parenchymal volume,
Yeah.
tumor volume.
Mhm.
They don't really go into the
The
contrast
nitty-gritty.
enhancement.
Sure.
So we decided to, and this is really some of the work from Eric Kaufman at Roswell, who was an NCI trainee, and he said, well, let's put this to the test.
Yeah.
Let's see. He retrospectively looked at tumors that were biopsy proven or removed, oncocytoma versus chromophobe. They calculated this score that he called peak early enhancement ratio.
Okay.
And in addition to a biopsy that showed a tumor marker called c-KIT, if c-KIT was positive and the peer score was high, there's 100% sensitivity for oncocytoma.
Okay.
So we said, okay, if we need to divine onco from chromo, how are we going to do this? Let's look at sestamibi,
Okay.
which had publication data is
Yeah.
used, versus this radiographic test.
Sure.
And so we designed a trial to test that.
Yeah. So that trial is currently ongoing?
Yeah. So we got funding from the Rising Tide Cancer Foundation.
Okay.
We plan to accrue 100 patients
Okay.
who have T1 renal mass,
Okay.
like less than 7 centimeters,
Sure.
who are planning on getting a biopsy or surgical resection.
Yeah.
We're blinded. Every patient gets assessed to MEBI, and they get a peer calculation. And then it's really simple. You remove the mass, you biopsy the mass, you see was it sestamibi positive or negative, was it peer score positive or negative in light of the c-KIT CD117 staining.
So, okay.
So our former trainee, Heathen Patel, is presenting that data at the AUA this year.
So sestamibi can help us differentiate what's benign and what's not benign, but there's a new molecule called girentuximab, and I think that's a bit of the inverse, right? So it can help us determine what's actually cancerous. So tell us, what is girentuximab?
This is really exciting
Yeah.
because we were talking about, we started talking about these benign tumors
Yes.
and chromophobe, but we mentioned that 75 to 80% of all these renal masses could be clear cell renal cell carcinoma. That's a real cancer.
Yeah.
That can grow, that can spread.
Yeah.
So girentuximab is a monoclonal antibody to carbonic anhydrase 9, also known as CA9. So clear cell, most of these are characterized by loss of VHL.
Yes.
And when you lose VHL, you get overexpression of CA9.
Okay.
And there's been lots of histology papers looking at CA9 expression.
Yeah.
But they developed a monoclonal antibody
Yeah.
that can bind CA9,
Okay.
and they, just like sestamibi, they put it to a radionucleotide.
Yeah.
So now the idea is you have a mass. If 80% of these are clear cell,
Yeah.
which is the bad guy, now you could inject, in a non-invasive radiology test,
Yeah.
you might be able to detect clear cell.
Yeah. Yeah. And there was actually a recent clinical trial called the Zircon clinical trial that kind of looked at this in a more clinical trial setting. Give us a broader overview of what that trial showed in terms of the data.
Yeah, so the Zircon study enrolled about 280 patients with small renal masses.
Yeah.
All these patients got the girentuximab agent, the CA9 antibody, and then they went on to surgical resection.
Yeah.
So it's a really simple trial design.
Yeah.
And the primary endpoints were sensitivity and specificity.
Sure.
And in that trial, it showed sensitivity of about 85%,
Okay.
and more impressively, specificity was in the same range.
That's amazing. So obviously, if something comes up positive, you can clearly tell a patient that I think there's a high chance this is cancer. We're not necessarily guessing anymore. A
Right.
very, very unique imaging study to be able to help us
Right.
determine that, right?
Yeah.
And is this drug available at this point, or is it still under investigation?
It's still it's being considered by the FDA.
Okay.
So it could be released anytime.
Yeah. Where do you find all these tools to fit into your clinic, right? Whether it be sestamibi, girentuximab, the peer ratio. How do you really sequence all these things and put them into your clinic?
So we can't use girentuximab yet.
Yeah, yeah.
But I think if girentuximab is approved
Yeah,
to detect clear cell,
yeah,
this is going to maybe change the workflow.
yeah,
So a patient comes in now. Let's just take a patient, 3 centimeter solid enhancing renal
Yep.
mass. You look at it and you go, I don't know, this could be cancer. Why wouldn't you do a girentuximab scan first
yeah,
to see, is it a clear cell,
yeah,
right? If it's negative, now we're back to non-clear, right?
Yep.
We've gotten rid of the more
worst
aggressive,
actor.
the worst actor.
yeah,
So now we're going non-clear. What's
Yeah.
non-clear? Papillary,
yep,
Pap type 2. But then the real one is chromo versus onco that we discussed before.
Correct.
Could it not even be a cancer? And
Yeah.
that's where we go back to sestamibi,
sure.
peer, roll of biopsy.
Yeah, I mean, I think if you look at just what we had 15 years ago, we have none of this, right? I mean,
Yeah.
sestamibi was around, but really not using this application. I think in the coming future, it's going to be so exciting. We're going to be able to better characterize these lesions with, I think, a high degree of accuracy, when we sequence all these methods, when we look down to it, right? So I think it's going to be a really exciting time in the small renal mass world.
Yeah, it's like a radiological revolution, really.
Yeah.
I mean, these renal scans are going to change the game, I think. Patient comes in, you get the girentuximab. If you're clear, you do decision making based on that with a high probability that it is that. If it's not, you go to a sestamibi or the data that was obtained in the MRI and biopsy.
Yeah. What does all of these tools or even other further molecular markers, what is that going to change our practice in the next 5 years?
Well, I think hopefully we'll be avoiding doing unnecessary surgery.
Yeah,
When we sit down with the patient, we have better prognostic tools, right? We can speak with data.
Yeah.
And we can, because, really we're there to guide the patient's decision making.
yeah,
And so maybe something would be, they would feel more comfortable with surveillance, which might actually be the best course of action for them.
yeah,
Because, a patient can, they have desires and wants too.
absolutely.
But if now you have some data, you can have a more informed discussion.
Yeah. So, I think there was a great conversation. We do like to ask every guest who's on Beyond the Biopsy one question when we close it out is, what is something in the last 2 years that you've changed your mind on? And it can be clinical or non-clinical.
I don't want to remove surgically masses that are not cancer.
Yeah,
And that's my real goal.
yeah,
You can present it as a high five to the patient. Hey, we did your surgery, you did great. By the way, it wasn't cancer.
yeah,
That could be a win, but is it really?
yeah.
And so my goal is with these tools, hopefully to do 0 benign resections.
Gopal, thank you so much for your time today. This was a really great conversation. I appreciate it.
Yeah, thank you for having me.
Of course.